Joys of technology. Hi everybody, so I'm Sarah Paterson and I am in my final year on the Consultant Practitioner Trainee programme on the stroke and neurology pathway, and I am going to tell you today just about a project I've been doing currently across the integrated care system in Dorset with the population health management team. So it's a little bit about how I've brought QI methodology into another data management approach in bringing rehabilitation across the system. No, I'm going to have the same problem as Tony, sorry. Joyce. So a little bit of background to the project. Back in March time, while I was still working with Health Education England, was introduced to the integrated rehabilitation model. So this is a model that's been proposed by the Community Rehabilitation Alliance, and it's what particularly sang to me about it was that it's very holistic, it's person-centred, and it's very much around the what matters to me approach. My clinical expertise, as I say, is as a physio in stroke and neurology, and my current research is around supporting people to be more physically active after stroke. So I've always had an interest in self-management and how we support people to return to activities that are meaningful to them. So this was something really important to me, and we had the opportunity in Dorset to have a look at whether we might be able to pilot this model. Now, on initial conversations, we realised that actually we don't have a very good understanding of what rehabilitation need is in Dorset. So before we can start to pilot a model, how do we understand this better and know where we can look at implementing this model? We also need to know how we best meet rehabilitation need. How do we change that culture of thought about what can our service provide to this person to what does this person need? And so to start those conversations, not about what each individual clinician is able to provide, but what opportunities are out there across the system. So I started working within the population health management team hosted by Dorset CCG, and was using this approach of population health management. So it's data-driven planning to deliver more proactive care to support the needs of patients in Dorset. So the first thing that's been really important is really using data, as some of my colleagues have acknowledged, to tell the story. And one of the starting points was in talking to patients in the system. We understand, I think intuitively, my thought was that we understand how we deliver rehab further up the triangle. So you'll be able to see on that left-hand side, those kind of complex acute patients and patients with multiple long-term conditions with complex needs. I think we understand quite well, and we've got services to support them. But how do we provide a more proactive model to support people that are currently healthy or starting to live with increasing numbers of long-term conditions to prevent them being that needing that reactive service that we're currently providing? And speaking to patients who are currently waiting for rehab really helped us show that although they wait for a long time, when they do reach rehab services, it's not necessarily meeting their need. So this was Bob, who I spoke to as part of the project, and his expectations were really that he wanted some support with how to get back out and about. He talked about building himself a bubble, becoming self-isolated, and this is really what he wanted help with. And so there might have been many other services that might have been able to support his need rather than waiting 14 weeks for a therapy appointment. But it was really important to understand this across the system, and as Tony said earlier, to be able to sense check whether this was kind of a true understanding. And so I did some work with the community rehabilitation teams, and again focusing on that bottom of the triangle. So I had about 30 conversations across the system, and within community rehab, most teams prioritise their populations according to kind of acuity and risk. And you'll see from that bottom part of the chart in the middle that it looked like there was potentially an unmet need or a kind of different way of prioritising, that we weren't necessarily being able to provide that proactive rehabilitation to meet people's needs in the bottom of the triangle. Looking at process mapping, processes are really linear, pathways are linear, so often the wider offer services, so services to support patients to self-manage, weren't considered until the end of a rehabilitation intervention. And there was just then queries starting to come up as to whether we could look at a different order for that. And also being able to highlight again, to define what rehab need is in this population, highlighting that mobility and function were really key elements that people had needs around, and who was the best place and where was the best place to be able to support these needs. So just to, again, sense check, but on a wider aspect, I was using the same questions really about defining rehab needs and starting to map some of the data that I was collecting across the system, but also across that triangle of need. So thinking about what the needs were for our complex and acute patient groups, but also what the needs were lower down the triangle to support people living with long-term conditions. And it was quite interesting gathering data from services such as Live Well Dorset, which are very much about supported self-management. Much of the need was again around physical activity, and this linked in with some of the lower prioritised patients within community services who had requirements around mobility. So again, it was just sense checking and using QI methodology to understand the characteristics across the system. And we were able then to start to get an idea, as you'll see on that right hand chart, that if you look at the top of the triangle, so the light blue, people were very much talking about risk of deterioration, risk of admission, acuity and complexity. Whereas if you talked about people lower down the triangle, it was more conversations about managing multi-morbidity, helping people to understand their conditions and providing social support. So already we were starting to get some differences in the rehabilitation need of these population groups. And then just finally starting, I haven't finished the project yet, but this is kind of the steps I'm onto. So actually using driver diagrams almost towards the end of the project rather than the beginning, but to start to bring some change ideas for use across the system. So thinking at the 3 different levels. At a systems level, Dorset are really fortunate to have a very comprehensive dashboard of data, but starting to use some of the data that I've collected to identify markers so that we can think about what rehab need is to be able to proactively target those population groups. At a clinical pathway level, thinking about how we might be able to integrate pathways better so that we're not necessarily getting that linear referral to therapies and then thinking about supported self-management afterwards, but integrating pathways a little bit more effectively. And at the patient and clinician level, really a lot of work around that cultural thought about what matters to you through every kind of appointment, so that each time the clinician is working with a patient, one, thinking about what matters to them, but also about what else is available across the system that might be able to support this patient's needs. So just finally, how's this helped me moving forwards? Hasn't helped me to learn how to use technology, sorry. Really what this project has really shown me is how we can use data to tell a story. It's been helpful, as others have alluded to, using QI to bring structure to complex and big problems. So although we've got big data sets, it's enabled me to focus in on what the need and the problem really was. As I say, using data to tell a story to help explain change, reasons for doing things and to help people really understand the current situation. So just kind of moving forward, I guess, into future roles, to be able to have that structure, that methodology behind me, to then be able to tell that story and bring people with you on a journey when you're trying to look at service change. Thank you very much.